This is the audio lecture for Chapter 5, Sexually Transmitted Infections. Sexually transmitted infections includes more than 25 infectious organisms transmitted sexually. Estimated that more than 19 million people are infected annually. And the most common STIs in women are chlamydia, human papillomavirus, gonorrhea, herpes simplex virus type 2, syphilis, and HIV infection. Who are those that are at higher risk for contracting an STI? Groups at risk include African American youths, abused youths, homeless youths, young men having sex with men, gay, lesbian, bisexual, and transgender youths, people who have multiple sexual partners, and those who participate in unprotected sexual intercourse. What are the factors that place teenagers at risk for STI? In females, it's the anatomy that predisposes them to STIs. Teenagers often have feelings of invincibility, like nothing is ever going to happen to them, that they're indestructible. Teens usually have more unprotected intercourse. They are in partnerships of limited duration. They have a new boyfriend or girlfriend every month, every week, so they don't stay in long-term relationships. Then the obstacles that are there that prevent them from seeking health care. And you can also refer to Table 5.2, Box 5.1, and the Teaching Guidelines 5.1 in your textbook. So this is Table 5.1, and it's talking about STIs and the effects on the fetus or the newborn. So let's talk about chlamydia. It can be infected through delivery. Eye infections, the baby can get neonatal conjunctivitis, pneumonia, low birth weight, preterm birth, and stillbirth. Gonorrhea, they can also contract that during delivery. It can cause rhinitis, vaginitis, urethritis, inflammation of sites of fetal monitoring, chorioamnionitis, preterm birth, and IUGR, which stands for intrauterine growth restriction. And in the baby, gonorrhea can cause ophthalmia neonatorum, which can lead to blindness and sepsis. So this is going to become very important when we start talking about pregnancy and all the things that can happen during the pregnancy and how it can happen and cause the birth to become a high risk. My genital herpes contamination can occur during birth. It can cause intellectual disability, blindness, seizures, premature birth, low birth weight, and even death. And typically we find that babies will die if their moms contracts genital herpes during her pregnancy, because when they contract it for that first time, it's a systemic infection versus if they've already had exposure to herpes and they have an outbreak, the outbreaks are more localized. So moms who have a history of herpes prior to pregnancy, their babies tend to do better than moms who contract herpes for the first time while they're pregnant. Syphilis, it can be passed in utero. It can result in fetal or infant death. Congenital syphilis symptoms include skin ulcers, rashes, fever, weakened or hoarse cry, swollen liver and spleen, jaundice and anemia, and various deformations. Trichomoniasis or trich can cause premature rupture of the membranes. The mom's water can break early. It can cause preterm birth and low birth weight. And genital warts. Women may develop warts in the baby can develop warts in the throat, and it's uncommon but life-threatening. And typically, we don't have too many issues with genital warts unless the warts are in the perineum and they're actually blocking the birth canal where the baby can't get through. And I want to jump back to genital herpes. Moms who have a history of genital herpes, and when it comes time for labor, if they have an active outbreak, so they have active lesions, they must be delivered via C-section. So moms with a history of genital herpes and they have an active outbreak, when it comes time to deliver the baby, they must be delivered via C-section. Now we're going to jump to infections characterized by vaginal discharge. The first one we're going to talk about is Candidiasis, or you may hear vulvovaginal candidiasis, or monoliasis, or yeast infection. Yeast infection is one of the more common forms of vaginitis that women experience. Recurrences are frequent for some women. Candida albicans is the fungal species responsible for most vaginal yeast infections. Factors that contribute to yeast infections are the use of oral contraception or birth control pills, immunosuppressant medications, and antibiotics, which destroy normal bacteria that usually keep the yeast cells in check. Other factors include frequent douching, pregnancy, and diabetes. And here you can also see women who have diets high in refined sugars and use corticosteroids are also at increased risk of developing yeast infections. Women with yeast infections complain of thick, curdy vaginal discharge, severe itching, dysuria, and dyspareunia, which is painful intercourse. A male sexual partner may experience a rash or excoriation of the skin of the penis and possibly itching. How do we screen for yeast? Usually we do a physical examination, and you can actually, when I'm doing my speculum exam and I put the speculum into the vajayjay, you can actually see this thick, white, lumpy, cottage cheese-like discharge attached to the side walls of the vajayjay. Medical treatment includes intravaginal the zoles, miconazole, ticonazole, clotrimazole cream. You can also do vaginal suppositories. A lot of these things are available over the counter. Nystatin vaginal tablets are available by prescription. And we can also do a dose of diflucan, which is also by prescription only. Women who continue to have symptoms after using an over-the-counter preparation and women who have recurrence of symptoms within 2 months should be evaluated during an office visit because inappropriate use of their birth control over-the-counter preparations can lead to a delay in treatment. Nursing management for yeast infection. Teaching preventative measures such as cotton underwear, avoidance of irritants. Some women, we like the perfumey type soap that you can get at Bath and Body, but all the JJs aren't made the same. So sometimes telling women to stay away from the perfume, body washes and soaps may help. Definitely good body hygiene and avoidance of douching or using tampons that are stronger than your flow. So if you know you flow very lightly, you don't want to put a Super Plus tampon in there. So this is straight out of your book, Teaching Guidelines 5.2 for Preventing Vaginitis. Avoid douching. Use condoms to avoid spreading the organism. Avoid tights, nylon underpants, and tight clothing. You need to let the cooch breathe. Got to get some air down there. Wipe from front to back after using the toilet. So good old hygiene. Avoid powders, bubble baths, and perfume vaginal sprays. Wear clean cotton underpants. Change out of wet bathing suits as soon as possible. This also goes for those who are workout addicts and you're working out and you get all sweaty. You know, you don't want to keep those same sweaty gym clothes on while you go run errands afterwards. As soon as you can get home or get to the shower, get out of those wet clothes. Become familiar with the signs and symptoms of vaginitis and then choose to lead a healthy lifestyle. So this leads us to a question. True or false? Trichomoniasis is one of the most common causes of vaginal discharge. The answer is false. Vulvovaginal candidiasis is one of the most common causes of vaginal discharge. This is just showing a picture of, like I said, when I put my speculum in, I can actually see the thick, white, lumpy, cottage, cheesy looking discharge on the vaginal wall. And this is what it looks like under the microscope. It's called hyphae. I say it looks like little tree twigs when you see it under the microscope. All right, trichomoniasis. Trich is an infection caused by Trichomonas vaginalis, which is a microscopic motile protozoan that thrives in an alkaline environment. Almost all infections are acquired through sexual intimacy. Transmission by shared bath facilities, wet towels, or wet swimsuits is possible, but typically it's quite unlikely. In females, symptoms of trich include a yellow to green frothy odorous discharge, frequently accompanied by inflammation of the vagina and the cervix, dysuria, and dyspareunia. Visualization of trich vaginalis under the microscope on a wet mount. Preparation of vaginal discharge confirms the diagnosis of trich. There's 2 other tests that have greater sensitivity. Don't really concern yourself with that. And the treatment for trich is metronidazole, aka Flagyl. Is administered in a single 2-gram dose, which is given orally or PO. One thing, if you have a patient who is on Flagyl, if you remember this from pharmacology, we tell them you cannot drink alcohol while you're on this medicine. And usually I think the CDC recommends 72 hours after taking the medication. You don't want to have had anything to any alcoholic beverages. We also recommend that if my mom tests positive for trichomonas, I need to get her sexual partner or partners also tested, and they need to be treated as well. Typically, we tell them to avoid intercourse until their repeat culture comes back negative. So once a person is diagnosed with an STI, we treat them and then we repeat the swab and we make sure that the treatment works. We call it a test of cure. So you want to make sure that if your mom comes in and she tests positive, her partners also get tested, they get treated, and that they need to avoid intercourse until both of their repeat cultures have come back negative. So this is what trich looks like under the microscope. Bacterial vaginosis, also known as BV, is more prevalent among sexually active women, but it is not considered a sexually transmitted infection. BV is an alteration of normal vaginal bacterial flora that results in the loss of hydrogen peroxide producing lactobacilli, which are normally the main vaginal flora. With the loss of this natural defense, bacteria such as Gardnerella vaginalis, mycoplasms, and anaerobes overgrow in large numbers, causing vaginitis. The cause of this overgrowth is not clear, although tissue trauma from douching, frequent sexual intercourse without condom use, and an upset in the normal vaginal flora are predisposing factors. If a woman contracts bacterial vaginosis during pregnancy, it can be a factor in premature rupture of the membranes and preterm birth. So when we talk about BV, like we said, we don't know the exact etiology, but we know it's just an excessive overgrowth of anaerobic bacteria. The discharge that you're going to see in a woman who has BV, it is going to be a lot of discharge. It is going to be profuse, thin, and white or gray or milky in appearance. Now, one of the telltale characteristics of the discharge that goes along with bacterial vaginosis is the fishy odor. So if you see fishy odor on a test question, you should kind of almost think that, yeah, we're talking about bacterial vaginosis, because it is stinky. It smells fishy, and I don't mean like you're eating a piece of salmon or trout at your local restaurant. This is red tide, fishy, stinky, smelly stuff. So this is a picture of how we diagnose bacterial vaginosis. This is what we call clue cells. Clue cells are characteristically seen in bacterial vaginosis. Unlike normal epithelial cells, which appear translucent and have a clear border, clue cells are disquaminated epithelial cells with bacteria adhering to them, and the presence of the bacteria makes the cell appear to be speckled with black dots. The borders are also obscured because of the bacteria. So this is what we're looking for when we're looking. And basically what we do, we get a sample of the discharge, put it on the microscope, cover it with KOH, let it dry for a little bit, and then you'll see these characteristic clue cells. Most hospitals don't do it on the unit. They just send down a swab, and it can test and tell us whether or not it's bacterial vaginosis. All right, moving on to infections characterized by cervicitis. Cervicitis is just inflammation of the cervix. And here we're going to talk about chlamydia and gonorrhea. So chlamydia is the most common bacterial STI in the United States. The majority of women with chlamydia are asymptomatic. The cause is Chlamydia trachomatis. Therapeutic management, antibiotics such as doxycycline or azithromycin. We typically like to use azithromycin because we can give them a one-time dose of 1 gram. Combination regimen if gonorrhea is also present. And since chlamydia is so popular out there in the United States, it's something that we do routinely with each annual exam. So if you're coming in for your pap smear, usually will ask you, do you want testing for STIs also? Nursing assessment, risk factors, adolescents, people with multiple sex partners, having new sex partners that have not been tested, sexual intercourse without condoms, those who use oral contraception because they're only thinking about not getting pregnant, they're not thinking about contracting an STI, pregnancy, and then history of another STI. Like I said, most women with chlamydia usually go asymptomatic. Most, I say 9 times out of 10, most women complain of symptoms like a UTI, burning, frequency when urination. They usually don't get a discharge. But for those who may get a discharge, you may see mucopurulent vaginal discharge, urethritis, bartholinitis, endometritis, salpingitis, dysfunctional uterine, and dysfunctional uterine bleeding. But like I said, most women who contract chlamydia often are asymptomatic. Urine testing or swab specimen culture is how we can diagnose it. I'm going to show you some pictures of what chlamydia looks like under the microscope, and here you can see this person has a little discharge with it, and if you look at her cervix, look how bright fiery red it is, and that's what we call the cervicitis, because your cervix is usually this nice pale pink color, but you can see her cervix is inflamed. So this kind of points me into the direction that there is some type of infection going on. Gonorrhea. Gonorrhea is the second most commonly reported infection in the U.S. It is highly contagious and reportable to health departments. Chlamydia is also one of those STIs that we have to report to the health department. The cause is aerobic gram-negative intracellular Diplococcus. Site of infection, the comminular epithelium of the endocervix. Gonorrhea is almost exclusively transmitted via sexual activity. And how do we treat it? Good old antibiotics. So we diagnose it by culture. Now, gonorrhea in pregnancy can potentially affect both mother and the infant. So in the mom, it can cause salpingitis, which is inflammation of the fallopian tubes. Pregnancy complication, premature rupture of the membranes. Her water can break early. It can send her into preterm labor. It can cause preterm delivery. And it can also affect the size of the fetus, which IUGR is intrauterine growth restriction. In my baby, moms who have gonorrhea and we let the baby pass through the vajayjay, there's a chance that they can get the ophthalmia neonatorum. This is the most common manifestation of neonatal gonococcal infections. If left untreated, it can lead to blindness, and that's why when babies are born, you see the nurse put the erythromycin eye ointment in the baby's eye. And cure for gonorrhea is rapid with appropriate antibiotic therapy. So my treatment of choice for gonorrhea in both pregnant and non-pregnant women is cefixime 400 milligrams orally once, or my favorite, ceftriaxone, also known as Rocephin, and that's 125 milligrams IM times 1. Now, the CDC recommends that if you have a person who tests positive for gonorrhea, we automatically treat them for chlamydia also, because co-infection is common. For some reason, if you're positive for gonorrhea, more than likely you're going to be positive for chlamydia. So if a person comes back positive for gonorrhea, we're going to treat them for both gonorrhea and chlamydia. Nursing assessment, risk factors for gonorrhea: low socioeconomic status, urban living, single status, inconsistent use of barrier contraceptive, age less than 20, and those with multiple sex partners. Like chlamydia, gonorrhea is most of the time asymptomatic. It can cause abnormal vaginal discharge, dysuria, cervicitis, abnormal vaginal bleeding, Bartholin's abscess or cyst, and PID, which is pelvic inflammatory disease. Also, like I said, the neonatal conjunctivitis if a woman gives birth and she is positive for gonorrhea. So in pregnancy, we test for gonorrhea and chlamydia. We do it at the first prenatal visit, and usually we repeat cultures around 36 to 38 weeks. So we do it at the beginning of the pregnancy and we do it towards the end of the pregnancy, because we want to make sure that the mom does not have an STI, especially if that baby is going to pass through the birth canal. These are just some pictures of gonorrhea and what it looks like under the microscope. This leads us to our next question. Which infection is characterized by a vaginal discharge that has a stale fish odor? A, trich, B, BV, C, chlamydia, D, gonorrhea. You better get this one right. The answer is B, BV, or bacterial vaginosis. So this is box 5.3 in your textbook, and it's the P-list model. P, permission, gives the woman permission to talk about her experience. LI, limited information, information given to the woman about STIs. SS, specific suggestions, which is an attempt to help women change their behavior to prevent recurrence and prevent further transmission of the STI. And IT, intensive therapy, involves referring the woman or couple for appropriate treatment elsewhere based on their life circumstances. Do not bog yourself down with that. We are going to move on to infections characterized by genital ulcers. And here we're going to talk about herpes simplex and syphilis. So first is genital herpes simplex. We know that herpes is a recurrent lifelong viral infection. It's transmitted by a contact with mucous membranes or breaks in the skin with visible or non-visible lesions. It can also be transmitted by a kissing, sexual contact, and vaginal delivery. Management, we know there's no cure for herpes, but we do have antiretroviral therapy to reduce or suppress the symptoms, shedding, and to extend the span in time of repeat outbreaks. Nursing assessment. Like I was saying before, the primary episode is the most severe and prolonged. This is the systemic part of this disease when you're newly diagnosed. It consists of multiple painful vesicular lesions, mucopurulent discharge, superinfection with yeast, fever, chills, malaise, dysuria, headache, genital irritation, inguinal tenderness, and lymphadenopathy. My recurrent infection, so she's already had her primary episode, now she's getting the outbreaks. And the outbreaks, like I said, they're localized and have a quicker resolution. When a person is saying that they're thinking that they're having an outbreak. They may complain of a tingling, an itching, pain somewhere in their genital area. So what I like to do, usually I have my mom's prenatal records, and if I see that she has a history of genital herpes, I always ask her, do you feel like you may be having an outbreak? So my little thing I like to use, do you feel a little tingle in your jingle? Because if she's having a little tingle in her jingle, I need to do some searching and see if I can find if there's actually lesions present. But like I said, if I have a mom who has genital herpes and she's it's time for delivery, she must be delivered by C-section. No vaginal delivery for her. Diagnosis is confirmed by a viral culture of the fluid from the vesicles. Now this slide just shows what genital herpes looks like. You can see the red vesicular lesions on the person's genital areas. Question: true or false? Recurrent infection episodes of herpes simplex virus are usually less severe and prolonged than the initial episode. The answer is true. We're going to move on to syphilis now. Syphilis is a curable bacterial infection caused by a spirochete, Treponema pallidum. It is a serious systemic disease if it goes untreated. Treatment or management of syphilis, good old benzathine penicillin G, which is given IM. Doxycycline if allergic to penicillin. And then we're going to reevaluate with serologic testing. My nursing assessment, what are you going to see if you're the nurse who's examining this patient? If they're in the primary phase of the syphilis outbreak, it's characterized by a chancre, which is a painless, indurated ulcer. Secondary flu-like symptoms, rash on trunk, palms, and soles, alopecia, and adenopathy. If they're in the secondary phase, latency, there's an absence of manifestation, and they will have positive serology. If it gets to the tertiary phase, this is the life-threatening heart disease and neurologic disease. This is when it becomes systemic, and it can cause syphilitic encephalopathy, syphilitic neuropathy. How do we test? And we do test for syphilis in pregnancy also. And if you're looking at your woman's prenatal records, you'll see VDRL or the RPR, and those are what we look for. We test to see if the mom has an active or a recent or past infection with syphilis. If her VDRL or RPR comes back positive, we're going to do a more in-depth testing, and we do FTA antibodies. Management, education. You can see the teaching guidelines on 5.3. Referral to support group, coping skills, and options for treatment. Offer them options for treatment and rehabilitation if it causes problems for them. And this is what syphilis looks like under the microscope. And this is the chancre that you see in the primary phase of syphilis. Okay, pelvic inflammatory disease. Pelvic inflammatory disease, or PID, is a clinical syndrome of inflammatory disorders of the upper female genital tract that includes any combination of endometritis, salpingitis, tubo-ovarian abscess, pelvic abscess, and pelvic peritonitis. The disease is more common in sexually active women younger than the age of 25. Other risk factors for PID include multiple sexual partners, a history of PID, a recent insertion of an intrauterine device. Remember I said IUDs. I say no to IUDs for hookers and hoes. You don't want to put an IUD in a person who's not in a monogamous long-term relationship and they're sleeping around with multiple partners. And regular douching. Perhaps the greatest problem of PID is post-infection tubal damage, which is closely associated with infertility. And remember when we talked about infertility last week. So my PID is a result of ascending polymicrobial infection of the upper female reproductive tract. Usually you see it in women who have untreated chlamydia or gonorrhea. And remember, chlamydia and gonorrhea in most of my women are asymptomatic. So a lot of times they don't know that they have this infection. And this infection can be raging in their internal reproductive organs and causing major damage. Management, broad spectrum antibiotics, fluids, bed rest, pain management, comfort measures include analgesics for pain, and all other nursing measures applicable to a client confined to bed. Now, one thing with PID, this is it's a painful disease, and typically when women come into the ER, they're kind of doubled over, holding their abdomen because they're in so much pain. And one thing that we do when we do our pelvic exam, the practitioner, the doctor, the midwife will touch their cervix and move it backwards and forward, like move it side to side. And if a woman truly has PID, she will come off the table. We call that chandelier sign. Or you'll also hear cervical motion tenderness. It's very painful disease. Nursing assessment, risk factors. Is she a hooker or a hoe? Does she have multiple sex partners? Is she having unprotected sex, not using condoms or barrier methods? Your manifestations, lower abdominal tenderness, adnexal tenderness, and cervical motion tenderness. Diagnosis, endometrial biopsy, transvaginal ultrasound, or laparoscopic exam. Typically, they're going to come back positive for either gonorrhea or chlamydia. Management, hydration, analgesics, definitely education to prevent recurrence. If she has an IUD, guess what? I'm taking that IUD out. And sexual counseling. You can also see teaching guidelines in your textbook in 5.4. Moving on, vaccine preventable diseases. We're going to talk about HPV, and we're going to go a little bit into Hep A, B, and C. Just a tad bit, because these you should have had in your med-surg course. So, human papillomavirus is the most common viral infection in the United States. We know that HPV causes genital warts or condylomata. There are 30 serotypes, 5 causes genital warts, and out of these, 8 are thought to have cancer-causing factors. So, you know, when you hear about HPV, you always hear about cervical cancer because HPV is one of the causes for cervical cancer. Manifestations, most are asymptomatic, and if they are symptomatic, typically they're going to have the genital warts. We can diagnose HPV with Pap smears. You'll see it on the Pap smear, and now when we do Pap smears, we do what we call co-testing. So whenever you have a Pap smear, they automatically test for HPV also. Therapeutic management, primary prevention via vaccine and education, treatment of the lesions and warts, secondary prevention via education. And like we learned in class the other day, they've extended the age for receiving the Gardasil up to 45, and usually it had stopped around age 28. Teaching about prevention is part of our nursing management, promotion of vaccines and screening tests, so encouraging both men and women to be vaccinated for HPV, and then educate about the link between HPV and cervical cancer. Symptoms of HPV lesions called Condylomata Acuminata. Almost sounds like Hakuna Matata. They are most frequently seen in the posterior part of the introitus, but can also be seen on the buttocks, vulva, vagina, anus, and cervix. Lesions are usually painless, but can be uncomfortable. You try sitting on a vine of grapes. Not the best feeling. They can have chronic vaginal discharge, itching, and painful intercourse can occur. HPV infections are thought to be more frequent in pregnant women. The incidence increases from the first trimester to the third, and the lesions, if they have the genital warts, they're going to get bigger while the mom is pregnant. Infection may be acquired by the neonate during childbirth. The frequency is unknown. And like I said, unless the genital warts are interfering with the baby coming out the birth canal, these women can deliver vaginally. Diagnosis is made by colposcopy and direct visualization of the growths or by biopsy. Prevention of HPV, long-term monogamous relationships, abstinence from all sexual activity, and vaccination. And we already talked about the Gardasil. So my genital warts, the Condylomata Acuminata, is highly contagious and sexually transmitted, caused by some subtypes of the HPV virus. It is spread through direct skin-to-skin contact through an oral, genital, or anal sex with an infected partner. Gardasil is a vaccine that protects against HPV type 16, 18, 16, 11, and we know that type 6 and 11 causes genital warts, and 16 and 18 causes cervical cancer. Genital warts may disappear without treatment, but sometimes eventually develop a fleshy, small raised growth. There is no way to predict whether they will grow or disappear. We can treat them. We can use Aldara cream, cryosurgery. We can freeze them off, electrocautery. We can burn them off, laser, 5-FU cream or Condylox. The thing with treating genital warts is sometimes difficult, and typically they do come back. And here are just some of my good old gross pictures of what the genital warts looks like. All right, moving on to hepatitis A. Hepatitis A virus infection is acquired primarily through a fecal oral route, and I usually say from mouth to ass. So think of those who go to the bathroom and don't wash your hands, like the people who work in restaurants and around food. So like I said, through the fecal oral route by ingestion of contaminated food, particularly milk, shellfish, or polluted water, or via person-to-person contact. Typically, you're going to get influenza-like symptoms such as malaise, fatigue, anorexia, nausea, fever, upper right quadrant pain, Testing, serologic testing to detect the immunoglobulin M antibody confirms acute infections. Because hepatitis A infection is self-limited and does not result in chronic infection or chronic liver disease, treatment is usually supportive. Medications that might cause liver damage or that are metabolized in the liver should be used with caution. And there is no specific diet or activity restrictions necessary. There is Hep A vaccine and immunoglobulin for IM administration. They are effective in preventing most hepatitis A infection. Hepatitis B. You should all know about Hep B because we're healthcare workers. Hep B virus infection is an STI and is the virus most threatening to the fetus and neonate. Hepatitis B surface antigen has been found in blood, saliva, sweat, tears, vaginal secretions, and semen. Drug abusers who share needles are at risk, as well as healthcare workers who are exposed to blood and needle sticks. Perinatal transmission most often occurs in infants of mothers who have acute hepatitis infection late in the third trimester or during the intrapartum or postpartum periods from exposure to hepatitis B surface antigen positive vaginal secretions, blood, amniotic fluid, saliva, and breast milk. Hep B virus has also been transmitted by artificial insemination. Hep B virus infection is a disease of the liver and is often a silent infection. It can be fatal in adults. Symptoms of Hep B virus infection are similar to those of Hep A. They may also have arthralgias, arthritis, anorexia, nausea, vomiting, headache, fever, and mild abdominal pain. Screening for the presence of hepatitis antigen is recommended on all pregnant women at first prenatal visits. And yes, we do test moms for Hep B. Screening should be done on admission for labor and birth for women at high risk for infection during pregnancy or if prenatal test results are not available. All non-immune women at high risk or high moderate risk of hepatitis should be informed of the availability of Hep B vaccine. Vaccination is recommended for all individuals who have had multiple sexual partners within the past 6 months. In addition, IV drug users, residents of correctional or long-term care facilities, persons seeking care for an STI, your prostitutes, women whose partners are IV drug users or bisexual, and women whose occupation exposes them to high risk should be vaccinated. And you know the vaccine is given in a series of 3, and usually you get your first dose, then you get your second dose a month later, and then your last dose 6 months from the time you got your first dose. And as a healthcare provider or a healthcare worker, you should be immunized against Hep B because you are going to come into contact with a lot of blood and body fluids that are not your own. So you want to make sure you protect yourself. Hepatitis C. Hep C virus infection is approximately the most common chronic blood-borne infection in the United States and is responsible for nearly 50% of the cases of chronic viral hepatitis. The most common risk factor for pregnant women is a history of IV drug use. Other risk factors include STIs such as hepatitis B virus and HIV, multiple sexual partners, and a history of blood transfusion. Hep C is readily transmitted through exposure to blood. Currently, there is no vaccine to prevent Hep C, and it's transmitted through breastfeeding has not been reported. The only moms that we try to prevent breastfeeding, or we tell them, please try not to breastfeed, or we don't let them breastfeed our moms that are HIV positive, because it is spread through breast milk. The ectoparasitic infections, scabies, pubic lice, don't get too bogged down, because not going to ask you any questions on that. But, you know, the treatment, the permethrin cream or Lindane shampoo, definitely decontamination of bedding and clothing, treatment of family members and sexual partners. Three-tiered approach: eradicate the infestation, remove the nits, and prevent spread or recurrence. Never had a patient with pubic lice. I had a patient with head lice before, and I also had a patient with scabies, and you know, they kind of burrow under your skin and cause that itching. So like I said, don't get too bogged down in those. All right, HIV, or human immunodeficiency virus. An estimated 34,000 new HIV infections occur in the United States each year. An estimated 23% of these new infections occur in women. With HIV, you're going to have severe depression of the cellular immune system associated with HIV infection, which characterize AIDS. Although behaviors that place women at risk have been well documented, all women should be assessed for the possibility of HIV exposure. Once HIV enters the body, seroconversion to HIV positivity usually occurs within 6 to 12 weeks. Although seroconversion may be asymptomatic, it usually is accompanied by a viremic influenza-like response. These symptoms include fever, headache, night sweats, malaise, generalized lymphadenopathy, myalgias, nausea, diarrhea, weight loss, sore throat, and rash. Transmission of the virus from mother to infant can occur throughout the perinatal period, and exposure may occur to the fetus through the maternal circulation as early as the first trimester of pregnancy, to the infant during labor and birth by inoculation or ingestion of maternal blood and other infected fluids, or to the infant through breast milk. Typically, we test women. All women are offered HIV testing, and we test them twice during the pregnancy. We test them the first time at the first prenatal visit, and then we retest them 12 weeks later. The woman with HIV also should be assessed regularly for serologic changes that indicate the disease is progressing. This is determined by the absolute CD4 T lymphocyte count, which provides the number of helper T4 cells. When the CD4 plus counts fall to 200 or lower, opportunistic infections such as pneumocystis carinii, pneumonia, are more likely to develop, and prophylaxis may need to be instituted. Screening and diagnosis. Screening, teaching, and counseling regarding HIV risk factors. Indications for being tested and testing are major roles for nurses caring for women today. Counseling before and after HIV testing is standard nursing practice today. It is a nursing responsibility to assess the woman's understanding of the information such a test would provide, and to be sure the woman thoroughly understands the emotional, legal, and medical implications of a positive or negative test before she is ready to take said test. HIV in pregnancy. HIV counseling and testing should be offered to all women at their initial entry into prenatal care as part of routine prenatal testing, unless the woman declines it. The panel recommends a scheduled cesarean birth at 38 weeks of gestation for women with a viral load of more than 1,000. A vaginal birth may be an option for HIV-infected women who have a viral load of less than 1,000 at 36 weeks. If a woman has ruptured membranes and labor is progressing rapidly, or if she declines a C-section, intravenous zibutidine or AZT is recommended for all HIV-infected pregnant women during the intrapartum, which is the labor and delivery time. The drug is administered 3 hours before a scheduled C-section and continue until the baby is born. It should be given during labor if the woman is having a vaginal birth. And my drug of choice that I use to treat my women who are HIV positive is zibutidine. We start them on the oral zibutidine while they're pregnant, and when they come in for labor, we start them on the IV zibutidine. The fetal neonatal risk. HIV transmission can occur during pregnancy and through breast milk. However, it is believed that the majority of all infections occur during labor and birth. In the United States, the rate of transmission has dropped dramatically and is now less than 2% of pregnant women infected with HIV who receive their antiretroviral therapy give birth by elective cesarean at 38 weeks before the bag of water breaks and avoid breastfeeding. Doing this will decrease transmission, and if a mom is HIV positive, following birth, HIV infection in infants should be diagnosed using HIV virologic assays as soon as possible, with initiation of infant antiretroviral prophylaxis immediately if the test is positive. Typically, a mom who comes into labor who is HIV positive, if she's going to deliver vaginally, we try and keep a hands-off approach because we don't want to do anything that's going to increase the risk of transmitting the HIV to the baby. So we typically won't break her water. We try and limit our vaginal exams. She has to do everything on her own. But like I said earlier, based on her counts or her viral load, if her viral load is not at the recommended level, we opt to do C-section at 38 weeks. This is before, usually we try and get them before they go into labor, before their bag of water breaks, because the more the baby is exposed to the vaginal secretions, that increases the risk of transmission. All right, preventing STIs. How do we do that? Education, education, education. So you're going to educate about safer sex practices. You're going to educate on the different signs and symptoms. Definitely changing behavior. If they have multiple partners, try slowing down a little bit. Talk about use of barrier methods to prevent the transmission. And things like that. But in your textbook, Guidelines 5.1 and Box 5.4 goes over these prevention strategies. So this is Table 5.4, which is the maternal and fetal effects from sexually transmitted infections. So it goes over the maternal effects and then those effects that you may see in the baby. This might be a good chart to look at and read and see how these STIs, what effect they have on the unborn fetus. Then the cultural and psychological components of STIs. All individuals who are sexually active are vulnerable. You're going to see Box 5.2. As a nurse, you need to be aware that in many cultures, the suggestion of testing may be considered offensive. Diagnosis often triggers embarrassment, guilt, fear, and in some people, intimate partner violence, because if one partner knows they're being monogamous and they still end up getting an STI, that means the other partner is not being monogamous and is out there fooling around with other people. Empathize with the woman's feelings. Suggest specific ways of talking with partners that will help decrease her anxiety. And like I said, be aware of possible intimate partner violence. This concludes the audio lecture for Chapter 5. Thank you.